You bet.
So actually, while we're gathering, why don't you go ahead and put in the chat where you are tuning in from, and quick word about why you're here. I want to make sure that I address everyone's concerns and questions. During the presentation itself, I won't be able to see the chat box, so I will. Good to have those questions visible ahead of time, if you have a moment. Everybody know how to use the chat box. It's down at the bottom, it says chat. If you click on that arrow, then you can open the chat box and enter your questions. Welcome, Sandra. Welcome, Carol. All right, we're still gathering a few people here. I know it's, thank you for those who are here. Great, so somebody from Suquamish. Great, making end-of-life decisions regarding what I would do if diagnosed with dementia. Yeah, that's a good thing to know what to do ahead of time. And we'll talk a lot about the conversations, because that's key. It's one thing to fill out the forms, but somebody needs to know. I'm wondering if I could ask for a co-host so that I can go ahead and get started and someone else can allow people to join. I have a volunteer for that. Somebody comfortable doing that?
I wouldn't know what to do. I'm
Amy?
sorry.
I'll make it.
If I understood the technology, I would.
Yeah, no, Amy has volunteered, so she's now co-host, and I can go ahead and start the presentation. All right, so we're going to close that attendance bar. And so welcome to this first of what I hope will be a series of dementia talks. I was very pleased at the response to have so many people say, yes, I want to know more about this, what the possibilities are for creating an advanced directive around dementia. How many of you, I'm curious, have just a regular advanced directive or living well? Raise your hand. I see some. Great. Yeah, so this is an addition to the basic advanced directive or living well. So that will be the important first step to take. And so I'd like to start actually though with a land acknowledgement. I am on Bainbridge Island, which was the territory of the Suquamish people. It was taken over by white settlers in the 1800s. It is a privilege to be able to live on this land and to enjoy the amazing riches of this land. And if you know the land indigenous name of the people who originally occupied where you are, please feel free to share that in the chat. So this is a vulnerable topic, right? Most of us know somebody with dementia, and it's not a fun thing to think about, but it is definitely something that's gaining more and more attention. We'll talk about the percentage of people, but basically half of the people in America will experience some form of dementia at some time in their life. And that's due to a lot of factors. Some of it is hereditary, but not that much actually. It's related to diet, related to lifestyle. And so there are things that we can do to put off the onset of it. There are certain conditions though where we are at higher risk. So let's do a quick check-in just to start with, and then we'll do a checkout at the end. Let me know in the chat how you are feeling right now as you think about dealing with this subject. Are you excited about finding out about it? Are you worried? And if everybody could mute, I will, that would be good for the recording. Mute those who are on. So let's see, we have people from Pawnee Sioux, Suquamish, Tongva, land of the Duwamish. Great. All right, Amy says it's always at the back of my mind.
Well, I'm on the other side of it. My husband had a kind of protracted end of life, several years of increasing dementia. But here I am, it could happen to me, and I want to plan it and go through it differently than he and I went through it. So if I need to go through it, I want to do it differently than he did.
Mm-hmm. Yeah, it, we'll talk about the time frame. It can be anywhere to 4 to 8 years, but longer too. And so yeah, and the burden on the caregiver is pretty extreme. So welcome, Kathy. We're just doing a quick check-in, how you're feeling about talking about this subject of dementia, Alzheimer's directives today. So,
hi.
Hi. Great to see people that I know and some new people as well. All right, so let's go ahead, and I'm going to start sharing my screen. Let me know, does that show the full screen? Somebody could unmute and
yes, it looks
okay.
great.
Wonderful. Okay, so let's talk about the why, the who, and the how. Can we gain peace around the topic of dementia? So as I mentioned, there are 2 directives that you need here. The basic advanced directive is something that anyone over the age of 18 can actually create, because that gives somebody else the power to make decisions for us if we are incapacitated. And the reason to do this is that, it's not just for the end of your life, but definitely also for incapacitation. It goes into effect when signed, which is the best thing to do. Some people don't want to do it until they get incapacitated, but we never know if we're going to have an accident or a sudden stroke, sudden heart attack. So it's really important to have it be effective as soon as it's signed. And if it's not the end of your life, you can revoke it if you regain capacity. So it's not like you're permanently signing over. So it only goes into effect if you lose capacity. So mental health advanced directive is what the dementia directive we'll be talking about today is actually called. The language is specific to Alzheimer's and dementia, so it's not giving over general power for all kinds of mental health issues. So this is a different sort of advanced directive, and it also assigns a person to make decisions for you. And then you get to decide, though, when it goes into effect. And you can decide that by putting in place certain markers. So for instance, when I can't recognize people around me, I mean, that would be extreme. So if you don't want to live that long, we'll talk about earlier markers. If anybody has seen that film, Still Alice, you're familiar with how she did it. Ended up not working for her, but those are the kinds of markers that you would set in place. And then you also get to decide whether it can be revoked or not. And this is a tricky thing because if you decide that it's revocable, you may or may not actually want to revoke it. So I'll show you some different options for that, but it is doesn't go into, you decide when it goes into effect and whether it can be revoked or not. So that's a little bit different from the regular advance directive. So who should create this kind of directive? Well, if you have a parent or sibling who has experienced dementia, you are probably at increased risk for it, especially for early onset. Long life also has a big effect on how many of us will experience it. The life expectancy has varied a little bit, but for white females, it's close to 85 now, I think. In my dad's case, he lived till age 86, and he was experiencing quite a few symptoms of it at the end of his life, probably the last year or so. And so, but if you have a history in your family, then you probably want to be looking at this before you have any symptoms. Other factors include a history of head trauma, other diseases like vascular disease, COPD, diabetes, quite a few other factors can increase the risk. And this is really scary. By 2030, nearly 10 million elderly will have some form of dementia. So that's coming up quick, and many of us are in that time frame where this is probably a good age to be thinking about it. So when can you actually start doing this document? Now is a good time. At least take a look at it. If you're not at any risk for it, I would at least, I'll give you a couple of different links to forms, and you can decide which one would be the most useful for you. I'm also going to have an offer for a group program where we'll go through this together, and you'll actually get it done. You'll get all the support you need. I'll talk about that some more at the end. Unfortunately, you can't create a directive for another person. So if you have somebody in your life now who is already in dementia, it's kind of too late. And so this is really aimed at creating your own advanced directive, or if you know somebody who is also concerned about this possibility, then you can share this information with them. All right, so let's just talk about the basics of dementia. As I mentioned, about half of us will, 10 million will develop dementia. So that's half of people in their 60s and older. There are many different kinds of dementia. Most common one is Alzheimer's. So 60 to 80% are diagnosed with that. But there's also dementia with Lewy bodies. There's vascular. There's Parkinson's disease related dementia. So it's there are a lot of ways that we can be affected by dementia. And so usually it's divided into 3 stages, and it can be difficult to sort of determine whether it's just somewhat normal aging or whether it's real beginning of dementia. A key thing is if you're losing the ability to remember what just happened. I know I've certainly experienced that. I walk into a room and say, why did I come into this room? But that's okay. It's if you're not remembering what's happened, sometimes the routine tasks become difficult. You're not able to drive even, to familiar places, but communication is still possible. So if you're beginning to see things like that or see them in somebody close to you, this is definitely the time to be talking about these things. Moderate dementia, communication becomes more difficult, and they really don't understand what's going on in their life. They need full-time assistance with dressing, activities of daily living. And this is when the agitation, paranoia, confusion might show up. But depending on their living situation, on who's around them, what kind of care they're getting, they may also be calm and just very happy and like, oh, life is good. So it's not necessarily the case that they will always be upset, paranoid, agitated. Then we get to severe dementia. So they don't have any recognition of family members or friends. Again, they might be calm and serene, but it's more likely that they're going to be severely agitated, even aggressive, and definitely experience paranoia because there's no foundation, there's no recognition of what's going on in their lives. They usually need 24-hour help with all aspects of daily living, and sleep definitely becomes more difficult. So how does dementia develop? Well, we've got these lovely lights in our brains that are going off all the time called brain synapses. And the connections between those synapses start to deteriorate. The brain actually starts shrinking, gets smaller, and it's not surprising that memory and language are the first things to be affected. And then the actual what's going on is that this amyloid plaque is slowing down the connections, and there's a substance called tau, which collects and just prevents the communication from happening. You may have heard about some treatments. There was a the names are very hard to pronounce, so I didn't even try. But there are few treatments, and they actually are like chemo. So you have to go to an infusion center, and there have not been any treatments that have actually reversed any of the symptoms. Some of them seem to slow it down, but it's not to the level that, I don't think Medicare pays for it right now, or you have to go through a long process to get permission to try the treatment. So how long do people live with this? Well, anywhere. There's really a huge range. If there's no underlying conditions, 4 to 8 years, but can be as long as up to 20. So that is a long time for somebody to be in that situation, and of course to be cared for, which is our next topic. So you have a couple of care options. So many people are cared for by family caregivers, and I know that several of you here have done that for a loved one, and you'll have time to hear a few stories, but it takes a huge toll on the caregiver. You can also be at home and have people come in to give assistance, and that is can get very expensive. And in this day and age, to actually find people who can do that, it's going to be a care crisis coming up with the number of people who are needing that kind of care. There's also assisted living, but the median cost for that is over $5,000 a month, just for basic care in an assisted living place. Can go as high as $12,000 a month if they need all support levels, and so that's not sustainable for many of us. There are alternatives to the big memory care places. They're sort of family style homes, and that can be nice because it's a smaller setting, gives you more of a sense of home, and the caregivers are definitely trained to work with people with Alzheimer's or dementia. And then, of course, there are nursing homes, and that's different from assisted living in that they're long-term, they're skilled nursing facilities. Probably not as nice as what we call memory care assisted living. So you do have options. You don't have to live for a long time with this. And we're going to talk about what some of those are. And you get to choose what kind of healthcare you want to receive. And that's why we would make this directive. So advanced directives are legal in all states, but dementia directives are a little bit different because it involves the possibility of withholding food and drink. And if you, in your regular advanced directive, you've indicated that you don't want to be put on life support, that's considered, and be in a persistent vegetative state, that directive will be honored. But that's assuming that you put that in place ahead of time. And when you lack mental capacity due to dementia, that's not so easy to get that choice honored. So you can obviously not have, don't want to be intubated, don't want to get fed by tubes, but to have them withhold hand feeding and withhold water, that is really tricky to get a hospital or even assisted living to agree to do that. And so that they might tempt you, they might offer you food, and if you don't have mental capacity, you're probably going to want to eat. So deciding ahead of time through this directive is really important. So if you even just open your mouth to receive food, then that's considered, I've overruled my directive to not hand feed me because I'm accepting food. So we'll talk about how we can avoid that situation. So I'll put these links in the comments in the chat when we get back to that screen, when I stop the presentation. It is legal in all states, so we always have the choice to choose what kind of healthcare, or have the right to choose what kind of healthcare we receive. And this is again where conversations are super important. It's not enough to just write it down, fill out the form. You really need to talk to your healthcare agent, make sure that they agree with you. So I'm going to talk briefly about these 3 different directives that are out there. And don't worry, I'll put the links in the chat and also send out the links in a follow-up email. So the first one is a very simple one, and that's at dementiadirective.org. It's 3 pages long. They talk about what you would want in mild and moderate and severe cases of dementia. It doesn't have any way to indicate who you want to be your power of attorney. So it's pretty basic. So if you are in a position where maybe you're young, maybe you don't have any family history, that might be one to look at, just to have it done quickly, and then at a later date, if you think that it's more important to have a more complete one, you can do one of the other choices. The second one is from compassionandchoices.org. They are a nationwide nonprofit that has so much information about how to make these directives, not just dementia, but regular advanced directives as well. And they have information on medical aid in dying and all kinds of good stuff. So they have one that is online, and it's a little bit complex. I had to go through it a couple of times. I actually watched a whole presentation on how to do it, and then it started making sense. And it's pretty involved. So you end up with a pretty good complete document, but it's a little bit harder to use especially if you're not comfortable with online forms and options. So my favorite is End of Life Washington. And yes, I happen to live in Washington, but I am a volunteer for them. I just did a presentation, as you probably saw in the email yesterday, about end of life choices. And I really believe in their mission. They've been absolutely critical in getting the Death with Dignity Act passed here. Recently, there were some updates to it that made it more accessible. So I won't cover that now, but so this is the one I recommend. Now, it is a pretty complicated form as well. The directions are probably 10 pages and the form itself is 14 pages. And so again, I'm going to be offering a class to go through this with you and help you with anything that you get tripped up on, make sure that you are making the right choices for you. And so we'll share that information and a link to sign up for that at the end. So let's talk about who makes a good healthcare agent. Should be the same person as your healthcare power of attorney on your advance directive form. And this gets a little bit tricky because somebody may be willing to support you in your general choices, but when it comes to not giving you food, not giving you water, letting you die by basically stopping eating and drinking, it can be really, really difficult. But then again, you don't want to have different people as your healthcare power of attorney for regular advance directive, different person for your dementia directive, and then they have to figure out a way to agree. So that can be a tricky situation, and your partner or the child that you're closest to may not be the best choice because of that. Maybe it's really important to find someone who will honor your choices. And again, conversations. It's good to have an alternate because maybe the person, your first choice is not available, or they're out of range. Maybe they're on a trip, but it's great to have two people. If you don't have an agent, then each state has a sort of order of who gets to decide. And in Washington, first is the court-appointed guardian, if there is one. Second would be your spouse or your partner. Third would be your adult children. And if you have more than one child, they all have to agree if you haven't designated a primary agent. If you have adult siblings, or parents would be next, and then adult siblings. So there's a whole list of who gets priority to make these decisions for you. And that goes for both regular advance directive and the dementia. So what are your choices if you get dementia and you decide that you don't want to, well, yeah, we all are going to die from something. So these are the options that you have with dementia. So those of you in Washington, and actually there are 9 states in Washington, D.C. who have death with dignity. It's kind of a weird name because we all want to die with dignity, but this is another name for medical aid in dying. So you get a prescription, you have to meet with 2 different doctors, and they make sure that you are actually okay with the decision, and then you get a prescription for medication. You have to be able to self-administer the medication, and so and you also have to have a diagnosis of 6 months or less to live. And as we saw earlier, it's rare that you're going to die just from dementia. Usually there's going to be something else going on that causes you to stop living. So death with dignity is not a great option unless you have an underlying condition that would give you 6 months or less to live. So next option is to actually live with dementia. And so if that's a perfectly valid choice, as long as you make sure that you have the resources to pay for that, and that you have a agreement, some way to get care that you need. If you do have an underlying condition, there's a form called the POLST, Physician's Orders for Life-Sustaining Treatment. And that's basically a DNR. And so you can, it's in Washington, it's a lovely bright neon green form. In other states I've seen it's bright neon pink. And that would go on your refrigerator, on the back of your door, somewhere very visible. And then if you have a heart attack or a stroke or some other disease and sudden emergency like that, you can either tell people not to call EMTs, not to call 911, or when if you do want them to come, then they would come and see the form and not do resuscitation. There are no guarantees, though, that the EMTs would follow that POLST. It's not a legal document. They can't sue them for trying to resuscitate you. So it's not a guarantee there. And then the last option is voluntarily stopping eating and drinking, shortened and called VSED. This is something that you have to really get informed about. We'll spend a lot of time in the class talking about this. It's a way to take control of your life and the end of your life while you still have capacity. I have a dear friend whose mother's mother, her grandmother, died with dementia, but only after living in assisted living for years. And her mom decided she didn't want to put her family through that. She didn't want to go through it herself. And so when she started exhibiting some of those milder symptoms, she put a plan in place to stop eating and drinking. It took about 2 years before she decided she was ready to do that. She was 73, I think, and could have lived for many more years. But she knew that she didn't want to live through that. She had a wonderful celebration of life beforehand, and really need to have layers and layers of support. And so VSED is complicated, and yet it is one of the best options if you don't want to go on for a long time with dementia. My father did VSED. He was 86, and that dementia wasn't the reason that he did it. He had severe pain, back pain and sciatica. He was in a wheelchair, so he couldn't really get around easily. And for him, it took about a week, depending on how healthy you are. When you start, it can take 2 to 3 weeks. And so it's not a undertaking for the, you got to have a really strong will and make a decision well ahead of time. It takes support from your family, and it's really important to have caregivers there to take care of your needs so that your family can be there processing their emotions, getting through their reality of their lives without you. It's a very brave thing to do. So we'll have time for some questions about that in a few minutes. So these are basically the options. You can live with dementia, you can get a POLST so that you die easily, relatively easily if you have a severe incident, or you can choose to stop eating and drinking of your own volition. So just share a little bit about this group program. It's going to start in May, and there'll be 2 sessions, live sessions, but you can also watch the replay if the time doesn't work for you. It'll be 5 to 6:30 on those Tuesdays. I'll also include a 20-minute one-to-one meeting with you so we can discuss the specifics of your situation. We'll complete the end of life Washington forms. There's also a directive about feeding that is part of the form, so we'll cover that base as well. We'll do a very thorough discussion of BSED and give you lots of resources for that. And basically what I'm offering is peace of mind for you and for your loved ones. So that is, I'm offering an early bird special. Normally it's $125, but until this coming Sunday, it'll be $99. And let me see if I can put that form in the chat right now. Let's see if I can be extra tricky and get this going. Maybe not. All right, I'll put it in when we go back together. So keep that in mind. So I'm going to pause the screen share right now. And yeah, got a lot to, that was a lot of information. So there's the link to the offer, and I will send that out in the email as well. So let's go ahead and unmute yourself if you have a question. I'm happy to address what I can and give you resources if it's something I don't know about. I'll check the chat while I'm thinking about this. While you're, yeah, anybody have a question? Or want to share an experience? I'd be happy to hear your stories too.
I have a question.
Yes, Joni.
So Kathy Frederick had to leave, but she talked about how unpleasant the experience was with the, deciding to stop eating and drinking. Do you think it always plays out that way? Like I said to her, I was under the impression that there are meds available, but you experienced it, right?
Yeah, so when you first start VSED, stopping eating and drinking, you don't qualify for hospice because hospice also requires a diagnosis of 6 months or less to live. But after, it's important to get in touch with hospice ahead of time, and then you have the opportunity to work with them once VSED is in progress, and obviously you're not going to recover from stopping eating and drinking. So the first few, you can talk to the hospice ahead of time. Hopefully you have a physician who supports VSED, and they can get the morphine and anti-anxiety medications that will alleviate many of those symptoms that can be experienced in the first few days. Very important to have, again, like I said, those layers of support. So one layer would be talking to hospice ahead of time. Another layer would be talking to your physician and seeing if you can get the drugs that will make it an easier process. My dad was very, very strong-willed, and he was already on hospice, so he already had that sort of support in place, the medications. And there's a group in let's see, I didn't put that form in here, but Bellingham called VSED Resources. And type the name of that in the chat. And they have lots of information in their books out there. .org, not .org. They have books available, so it's becoming not a lot more well known, but better known than it was. And it's how people used to die. We used to die at home. We had family around us. We just naturally stopped wanting to eat and drink. And it's not really nice to contemplate doing that, but the reality is after a few days, the body's organs start shutting down and you go into a coma. It really it can be very relatively easy. We all have to die somehow, unfortunately. I appreciate you guys being here and being willing to think about these things ahead of time. I see a question, is the registration for an individual or register as a couple? Yeah, a couple is fine. Somebody asked if we can get slides. Yes, I will be sending out the slides, summary, and all the links that I've mentioned.
One more
Johanna, when you were, sorry, the sun, you went through a little bit of a list, and I missed what was the start of that list. And you said the number one thing was the core, number two is spouse, number three is your designated like health agent, and then for adult siblings. What was this in regards to?
So that is who gets to make decisions for you if you don't have an advance directive in place.
Okay. All right. Good to know. Thank you.
And if you haven't even talked about what your choices would be, then imagine the difficulty of making those decisions for your loved ones.
One more question about the death with dignity is, you said that's not an option unless you have been determined that you only have 6 months to live. Is that correct?
Right.
Which is also what is required for hospice. So so that is an option if you qualify for hospice.
Yeah, the problem is that if you have dementia and you start VSED, there's usually not enough time to have the 2 different appointments and to get the medication and to actually ingest it. Because when you start VSED, within a couple of days, you are not really coherent anymore. So it's somebody asked that question yesterday. Can't we just start VSED and then do death with dignity? And it's pretty much impossible to do that because right now there's only, starting in July, actually in Washington, there's a week between the 2 different appointments because they want to make sure that that's really what you want to do. In other states, though, it's a longer time frame.
But you can choose death with dignity instead of VSED?
So yes, if you have a diagnosis of 6 months or less to live, and you are in full capacity, then you can. Yeah, but dementia does not qualify for the 6 months or less to live. What other questions you have? I feel like I went through the presentation pretty quickly. Let's see, is there a test that medical doctors use to diagnose or assess dementia? Yeah, there are different things that are used. And so if you are concerned about it, definitely make an appointment with your doctor. They'll do some memory tests, things like asking you, giving you an address and then asking you a bunch of different questions, and then go back and say, so what was that address? And see if you can, remember it. So that has to do with that short-term memory. And as I mentioned, the short-term memory and language are the first 2 parts of the brain that are affected by dementia. And that brings up a good point, is that we can make that list of markers. So if you say like, I can't remember my daughter's birthday, or I don't know what my wedding date is, something like that, that you know, just something that's pretty common that you would remember that. Dates are good things. Then, you know, you'd say, okay, it's time to start thinking about my directive and what choices I've made in that. Anybody see the movie Still Alice?
Yep.
Yeah, no, I recommend it. Actually, I recommend reading the book. I think it's a much more valid, just more in-depth exploration of how early onset dementia works. And she had these markers, and so she went through them, but she ended up not being able to follow through. She wasn't going to do VSED. She had collected enough sleeping pills to put her on. And so she, you know, she had the plan in place, but when she reached those markers, she went to get the medication, and then somebody rang the doorbell, and she got all flustered, and the pills went all over the room, and so she couldn't collect them, and she lost her opportunity. And so she hadn't told anybody else that she had these markers and that she had a plan in place. And so if you decide to create this directive and put a plan in place, have somebody know what your markers are. And maybe your partner or your favorite child is not the best person to do that, because we don't want to see our loved one go, right? So how about a good friend who will be honest with you and say, yeah, I really see that this is happening, and I know that we've talked about what you're going to do. Can we talk about actually doing it?
I seem to have all the questions.
Go for it. Go for it.
I don't know if you can speak to this, but so if you're not acting on your own behalf, but you have a family member that doesn't want to address it, do you know if physicians will make that assessment kind of not on the slide, but you know, if they're not a willing participant? Like I think there's the Medicare questionnaire that you can deny. You can say, I don't want to do it.
Mm-hmm. Yeah, it's worth talking to the physician and just say, I have concerns. It's especially good to do that if you have medical power of attorney, because then you have some document that says, yes, I have, you know, it's not in effect necessarily right then, but they're more likely to go ahead and be more open about that if you have some form that says you're involved in this person's healthcare. But yes, if you have full capacity, or even, you know, decide that the person doesn't want to do it, then you can't really force them to. That's funny, Christina, as you said, you never remember their wedding date in 35 years of marriage. So that's cute. If it's a change, that's when you maybe you suddenly start remembering it. Say it's a certain date.
Johanna, could I offer a different perspective about the physician involvement with regard to being the loved one of someone who might be experiencing dementia? So I worked in a couple of medical clinics where I had the title of, wellness advocate for patients or population health coach. And I often met with patients, and they were sometimes more candid with me than they were with physicians. I think, as in anything, a multi-pronged approach sometimes can get you farther than just, being frustrated with what doesn't work and then giving up. And so I would say that, maybe the physician is comfortable talking about that. My experience is most physicians are not. But there may be a nurse, there may be a social worker, there may be a health coach in that clinic who can just have a different approach with the patient and their family that would encourage some conversation rather than let's talk about making an advanced directive. how about, let's talk about, you know, how your shared happy memories as a family, and what are the bonds that hold you together, and kind of starting on that foot and moving forward. So just an alternative kind of viewpoint there.
Yeah, right. Going directly to the physician might not be the best course of action. And there's certainly, like you said, auxiliary people around who maybe have more experience. Great. Thank you so much, Sheila. I appreciate that. What other questions, or would anybody like to share their experience of taking care of somebody? Well, that's good then. Yeah.
I can share on that briefly. I did lose my mother to Alzheimer's, and when we needed to move her from her home, it was really, really tricky. And I listened to others that had had to do it before, and basically brought her a couple 100 miles south to my home. She got thoroughly mixed up, took her back the next day, I think it was, and drove around the city until she understood that I wasn't going to be able to take her home because the construction people were coming to work on her home. So she was going to have to stay in another location for a period of time. And that worked as well as anything. Nothing I felt works at the beginning when you're trying to move them. Just all the experiences that we went through with her make me personally lean towards stopping eating and drinking, as hard as it might sound.
Yeah.
I think one of the tough parts in that might be talking to my children about me making that decision.
Mm-hmm.
And especially the one, of course, that will be my health agent. So
Yeah, it's not the first choice of conversation to have. It's not an easy one. And once you've made the decisions yourself and then had the chance to have the conversations, and I'll be guiding you through that process as well. It's everybody experiences more peace of mind. Really can be really beautiful. So I'll put that link in one more time, and also I have a quick evaluation form that I would love to get your feedback on. That's the second link there. If you could just click on that now and open it, and then come back to this screen. It's really helpful this is my first time doing this presentation, and like I said, I imagine doing it again since the response was so great. And yeah, I appreciate you all taking the time to be here this evening. So if you want to stay on and ask anything more, I will be on for another 5 or 10 minutes. And if this is a good time to get off and go get some dinner or go rest, Sheila, since you're late, go ahead. I appreciate you being here so much.